of this presentation and our research, I'm going to do a small introduction about the kinematic analysis. You see, as orthopedic surgeons, we have to understand that a traumatic injury is an acute dissipation of energy in a split of a second. And the greater weight variable in the equation of the traumatic injury is the acute dissipation of energy. What is a little bit different when we are dealing with an orthopedic injury, when you have many other variables like balance, passive flexibility, strength, mechanical load absorption, anatomic alignment, static posture, all these variables, they are competing to the loading of all the joints and muscles. And there's another thing, we have time to develop those things. So whenever we have painful condition, we may have started to be fitting that problem many years ago, not like a traumatic injury that is just in a second. That's the reason we see people with complete different anatomies, valgus knee, varus knees, neutral knees, with absolutely the same symptom, like anterior knee pain or chondromalacia. So only anatomy does not explain all the problems, all the variables we may have competing to have pain in the knee or wherever. So when we have pain on the knee, we have to understand that orthopedic lesion is not just a matter of luck or destiny. And the image exams we have nowadays, they can evidence anatomical changes, but they cannot tell us what are the causes of those changes. So that's the reason there is a world trend to develop functional analysis. For instance, nowadays a cardiologist, a cardiovascular surgeon, they won't take any decision based on an auscultation or just an X-ray, not even a beautiful 3D image of the heart. They need functional analysis. That's why they have electrocardiograms, angiography, Dopplers, stress scintigraphies. These exams, they analyze the function of the cardiovascular system and not only the image, static image. And simply analyzing the motion of the human being is not enough. Because if a person has an exquisite motion, you have to understand why he has that motion. If he's limping, why he's limping. He may be limping because of restriction of range of motion in one of the joints, the hip, the knee, or the ankle. He may be limping because he has some weakness, maybe in the triceps, quadriceps, gluteus. So it's not simply to understand, to see 3D motion. We need algorithms that combine strength, static motion, posture, range of motion, motor behavior, and that has to be analyzed in 3D, in the coronal, in the sagittal, and the axial planes together. So it's a very complex analysis that we need to understand where is the reason for the overload of a joint. It's almost impossible to define that just with an orthostatic X-ray. For example, this patient over here had a 9 degrees varus, okay? But when we start analyzing in 3D, if you see that graph on the right side, you're going to see that his varus goes all the way to 13.5 degrees of, let's say, dynamic varus. So that would influence the surgeon to take the decision. Probably if he's doing an osteotomy or a uni prosthesis, the load has to be calculated not only on 9 degrees of varus, but 13.5 degrees. So we have to understand that sometimes the same dysfunctional, the same motor dysfunction may overload different points. For example, a hip incompetence can overload the knees, sacroiliac joints or pubis, lower back, ankles, and sometimes a combination of hip incompetence with a little bit of ankle incompetence overloads the knees. And so sometimes the knee is not the problem. Sometimes the knee is the victim of that. And another point that I find very interesting for this presentation is that sometimes people ask me if exercising, rehabilitation of the elderly is worth. Of course it is. It is. There are a lot of studies showing that the strengthening of elderly people is similar, the response to strengthening is similar to middle-aged people. So it's worth, yes, you can prolong the joint life with adequate rehabilitation, with adequate reconditioning of the muscles, the joints, okay? So it's worth rehabilitating seniors, yes. But the problem is that strengthening of seniors, individuals, is not the same as younger, but with lower loads. That's one of the biggest mistakes we see is whenever we send our patient for strengthening, then the PT or the trainer simply does absolutely the same thing he does with a young patient, but with lower loads. And that's not the point. We must optimize rehabilitation exercises. We have to optimize for their needs. And strengthening and enhancing motor control only of the muscles of groups and segments that really need. Elderly people, they don't feel confident when they do exercising and they don't see any change in their lives, you know? So it gets boring. So they quit. The dropout rate is huge. So the other point is pain control is needed to avoid muscle arthrogenic inhibition. It's absolutely impossible strengthening under pain in any age. In physiatry, we learned that there is no way your cerebellum does not authorize you to request all the muscles fibers you need for some movement if you have joint pain. It minimizes your muscle fibers that are requested for that job. So that's why when we operate, sometimes we do a ACL on the knee, the quadriceps, poof, simply goes to hypotony. So what we need to show cerebellum that there is no harm, there is no problem there is no pain. Pain is a sign of a problem. So, and the joint is okay, and then your cerebellum starts authorizing you to request all the muscle fibers again. So, a few years ago, we observed in this paper at the JBJS that was called Viscous Supplementation for Osteoarthritis of the Knee, a systematic review of the evidence. That's a very strong word to put in a scientific paper title. And when we went into the paper, we observed that the inclusion criteria were only randomized controlled trials. That's very good. For knee osteoarthritis, all stages. And all the stages of knee arthritis is a vast dominion with at least 4 weeks follow-up, okay? At least 30 subjects for group. And they were analyzing this at least 30 subjects for group by pain, function, through subjective prompts, those questionnaires like pain questionnaires, WOMAC, IKDC, Lisham. And we went back to the computer and we saw that for these subjective scores, we would need at least 199 patients in each arm of the RCT to have a statistic evidence or a statistic relevance. So that made us very curious about these conclusions based on very small sample sizes for subjective scores. That would be like analyzing the car owner experience about gas usage and in different cars. And you would need thousands of cars to have really a good impression about it. So we were motivated to do a study that would be more refined. We went to these systematic reviews and meta-analysis, and we start studying what was controversial, what, on their conclusions, what were the controversies the authors would discuss in their papers. And we saw that the authors themselves, they pointed, they bullet some changes, some things that were very important. In 9 of 10 papers, all of them showed methodology weaknesses on these RCTs. They said that most RCTs had small sample sizes. There are some RCTs with 11, 12 subjects analyzing subjective scores like WOMAC. Heterogeneity with Kellgren-Lawrence ranging from 1, that even maybe just a insole would help this patient, to 4, where a total knee would be needed. So it's very heterogeneity. Inadequate baseline measures, problems of blinding, randomization, allocation concealment, different injection protocols. In every paper, they have different protocols, duration of follow-up, lack of intention to treat basis, possible confounding factors, and conflict of interest with industry. So these were the most cited methodological weaknesses we saw in papers. So we were motivated to start our study about the effects of the viscous supplementation through three-dimensional kinematic analysis of knee osteoarthritis. We conducted a prospective double-blind randomized control trial. So we are a not-for-profit institution. The sponsor beforehand accepted publication, even if the results were not positive for their commercial interests. Our hospital facilities and everybody involved in this study were unpaid volunteers, and all expenses related to medication, laboratory analysis, equipment, rental, and transportation were provided by Epson, Switzerland. So the objective of this study was to develop a double-blind RCT to analyze the effects of intra-articular viscous supplementation subjects with advanced knee osteoarthritis, only Kellgren-Lawrence 3 and 4, before and 12 weeks after infiltration through 3D kinematic analysis, 3D gate spatial temporal parameters, and validated Portuguese pain and functional scores, the IKDC, LAFS, and pain analog visual scale. All patients were at the waiting list for a total knee arthroplasty at the Air Force Hospital, which is a military institution here in Rio de Janeiro, where the waiting time, the mean waiting time for surgery is 2 years. It's a long line. Our inclusion criteria were patients over 60 years old, any gender, body mass index, or race, capable of walking without any support for at least 10 meters, and Kellgren-Lawrence 3 and 4. So only very advanced cases. Our exclusion criteria were those we normally see in the literature, people with neurological condition or secondary to traumatic osteoarthritis, etc. Of course, we had a permission of the ethics committee, national ethics committee, and the hospital ethics committee, and we submitted this protocol to the clinical trials registry before starting. So to have a power of 80% with a level of significance of 5%, we needed 20 subjects in each arm of the study. So we had 156 patients. 114 were not included. Most reason is because it's a military institution, so many of the patients, they live elsewhere, they live in other towns and other states, far away from the hospital. And finally, we randomized 42 patients. We allocated 21 for each arm. We lost follow-up of 2 patients in each arm. One was because of stroke. The other one had a chikungunya fever with a mosquito-transmitted fever. 2 abandoned. So our final analysis was over 42 subjects with lost observation carried forward protocol. This is the hospital, the Military Air Force Hospital in Rio de Janeiro, where this study was conducted. It's a day hospital. It used to be the sector of our burned people, and they they reformed for a day hospital. And this was the admission, transport of the patients on stretchers. So the surgeon that would perform the injection, he wouldn't have a subjective analysis of the quality of gait of this patient walking in and out. So the nurses would take all the patients to the surgery room on stretchers. And this was the setting. We had this arthroscopy field covering, blinding the patient. We had an ultrasound. We had this surgeon that was an expert in ultrasound guided injection to the knee. We had different boxes with active drug and placebo. And the drug we used for physical supplementation was Synolase with 80 milligrams of hyaluronic acid and 160 milligrams of sorbitol. And we were very careful for blinding. Even the words we say in the surgery room where we practice beforehand. We practice on volunteers, on asymptomatic volunteers. And we cared even about the sounds. When we perceived that we needed to open the box of the Synolase, the patient could understand that the box of the medication was being opened. So we did the same for placebo, Steve. Now, this doctor is opening the active substance. So he would hand the Synolase to the physician that was going to make the infiltration, and that's the sound of it. So we did the same thing for the placebo. We did a placebo box that he needed to open anyway. So the patient wouldn't have this bias of hearing, opening the box of the medication or not. And over here, you're on the right side, you're going to see one of the patients being performed, all the steps of it. So for every patient, we perform a local skin anesthesia with 2 milligrams of lidocaine with a subcutaneous needle. We allocated after anesthesia. We opened the randomization envelope after the patient was anesthetized. And then we chose if it was placebo or active compound through the randomization. All the infiltrations were performed through the superlateral approach and guided by ultrasound. All supplies were deposited in boxes and closed before surgical fluid was removed. The envelopes returned to the randomization folder. All patients were oriented to maintain their routines like non-pharmacological treatment or physical treatment. Paracetamol and ibuprofen as rescue pain were allowed. Any compound with cortisone, either cream, capsules, or injections, were prohibited. Two blinded orthopedic surgeons were designated for follow-up or any intercurrence or emergency with a 24/7 exclusive cell phone. So these doctors, they didn't see the randomization. They were not in the procedure room, but they had instructions to help if patient had any kind of a fever or redness on the knee, etc. And one blinded secretary was designated for make all the appointments for the injections and for the 3D biomechanical analysis. For you to see in the next slide over here, you're going to see you here are seeing patients 40, 41, and 42. If you look at all of them, you see the routine is absolutely the same. The patient is already under anesthesia on the table. Then the randomization envelope is open, and then the box is open if it's active drug or placebo. And it's very interesting because all the patients, the injection procedure would take between 5 to 8 minutes. So it's a very quick procedure, only 5 to 8 minutes, and all guided by ultrasound. So we were sure that the hyaluronic acid and sorbitol was inside the joint and not outside the joint. For all patients, you can see the needle going inside, and it's very nice to see the hyaluronic acid going inside, like sparkles inside the joint. No patients looks like those sparkles going in. So all the procedures were performed the same way for all the patients. So the analysis we performed at baseline before injection and 12 weeks after time. So all the study time took 5 months. So in 5 months, we were able to do all the baseline analysis and now 12-week analysis. So everybody was blinded. Everyone in the collecting, processing, interpretation, and statistical analysis had no idea to which group all the patients were related to. So they answered the questionnaires. They had the 3D spatial parameters analyzed before and after, and they had all the electronic measures of strength, range of motion, and functional range of motion of gait and squatting. And we could see in the study that at baseline, no statistical differences between the groups were perceived, even for pain, for IKDC and LEFs. But after intervention, both groups improved in pain, both groups improved in functional analysis of the questionnaires, and both groups improved in questionnaires or IKDC, but without any statistically relevant difference between the groups. So subjectively, all patients, even placebo or active drug, they felt some kind of better. And with gait parameters after 12 weeks of injections, both groups decreased initial double stance analysis. They increased single leg stance time, they increased step length, and they increased stride length. So this tool also did not perceive any difference between placebo and active medication. But when we performed the 3D analysis, the thing was much different. The viscous supplementation group increased sagittal plane active maximum flexion and extension angles. If you see in the right graph, the blue line is at baseline, the flexion of the knee in baseline. And the red line is the flexion of the knee 12 weeks after. So the motion of the knee increased a lot. And what was also very interesting was this patient, they return almost to, let's say, close to normal flexion and extension of the knee during gait. And the placebo group decreased actual range of motion. So that allows us to infer many other things, scientific things. So sometimes patients return to our office after viscous supplementation injections. They say, doctor, I still have pain. But now they are walking much further. They're climbing stairs. They are doing more things in their life, and they absorb that for their normal lives with a better kinematic. And they only measure about, I'm feeling pain or not. That's why measuring pain is so complicated. But mechanically, they improve a lot. So the results of this trial demonstrated a similar improvement in pain, quality of life, gait spatial parameters after infiltration of viscous supplementation and placebo. But we should regard carefully with that, because injections with saline placebos have superior statistical and functional improvement when compared to oral pill placebos. And subjective scores, PROs, and spatial temporal parameters may not be the adequate tool to analyze changes in pain and function in small sample sizes. So that corroborates our idea that many of these RCTs that we see around, they use WOMAC, AKDC with small sample size. They may bring us a biased information. It's not that pain and PROMs are not adequate, but they may be the right tool to measure this kind of problem. It's like a ruler. A ruler is a perfect measure tool, but it's not for fever. We have to use the correct tool for this correct problem. And this study showed us that viscous supplementation improved the active range of motion in individuals with advanced knee osteoarthritis. With advanced knee osteoarthritis, we can extrapolate that for people with less aggressive knee osteoarthritis. And the 3D functional range of motion is a very sensitive to identify and measure changes in osteoarthritic knees, even in small samples, because it's a very precise measure. And there are numerous, hundreds of papers showing that increasing active knee range of motion and extension, flexion, is related to increasing quadriceps function, decreasing joint loads, improving gait functionality, and possibly increasing joint lifetime. So that's the point. Our conclusion is that infiltrations comparing viscous supplementation and placebo, they may not show any statistical difference in subjective analysis, small sample size subjective analysis or gait parameters, but they showed statistical significant increase in maximum active extension and flexion of the knee, and decreased total knee plane motion of the placebo group. For the For these studies, we were awarded with the highest honor in Europe, that is the Michael Freeman Award of Excellence in E-Biomechanics last year. I had the pleasure to receive this award from Professor Philippe Neret and Dr. Pierre Anderson. It was a real honor. And as a take-home message, I would say that total knee arthroplasty is the most effective evidence-based treatment to reduce pain and improve function in advanced knee osteoarthritis. If you put those keywords, total knee arthroplasty outcomes, in PubMed, you come out with 1,159 studies only for the past 10 years, and only with RCTs. So it's very well studied. And it is unfair that say, wow, risk of infection, risk of surgical problem. No, really, total knee arthroplasty, it is a very, very good procedure and very effective, and it works very well. The problem I see with that is that the knee osteoarthritis is a disorder progression that is unpredictable. No one can say that this problem is going to go further and you're going to you have a bad future. Knee osteoarthritis is a problem that with a slow onset condition usually need years of clinical management before surgical intervention or knee arthroplasty is indicated, if ever. Many patients live forever without any surgery. And the mean disease duration is from the first symptom to surgery, the mean is 2 to 11 years. So it's a long time. So we have to manage these patients. We can't simply let them, oh, stay home and live home. And when you're ready, we do surgery. No, these people, they need function. They need to live their lives. And the non-surgical treatment management, as said by Campbell, that is our partner in Chicago at the Rush University, he said, non-surgical management must provide significant improvement in pain and function with least side effects possible. So strengthening and rehabilitation is not possible under joint pain due to central arthrogenic inhibition. We need to minimize pain to allow rehabilitation of these patients and prolong their joint life. And just to finalize, we are very proud that we provide fellowship programs for Brazilians all, through the world. And we have just signed a new partnership with the Rush University. And this fellowship program we have in our institution over here. For the past 10 years, we have published 210 scientific papers, 17 books, 102 scientific presentations, 3 world awards, 12 academic superior positions, and we are going further and further every year, and we are very proud of our research. And as a final comment, I'd like to invite our friends from all over the world, whenever possible, to come to Rio de Janeiro, this marvelous place. If you don't come for the beaches and for join, we also have many high-level research institutions over here to share with you. Thank you very much. Thank you for my honor of this presentation.
Okay, thank you very much for Dr. Metsavaht's excellent talk. We learned a lot from his presentation, but we will leave the questions and answers to the end of all the talks. So may I invite the second speaker, Dr. Patrick Goh, to deliver his talk. on the hyaluronic acid versus corticosteroid in symptomatic knee osteoarthritis. Patrick, please.
Okay, hello. Thank you very much. Can you hear me, Dr. Jason?
Yes, I can.
Okay, great. Okay, I'll get going now. Let me just check my screen preference. Just give me a second.
Maybe you can speak a bit louder.
Okay, sure. All right. Thank you very much for the invitation. It's my honor. And a very good evening to all my colleagues in Hong Kong and around the region. And thank you, Dr. Metsavaht, for an excellent presentation. So my topic is to talk about hyaluronic acid versus corticosteroids. And, you know, this is always something which we debate quite a bit in the community. And the question I'm trying to answer today is this conundrum resolved? You know, which do we give and when do we give it? I noticed a question appeared in the chat box about PRP. And I've actually a lot to say about PRP, but just not this evening, because this evening I'm going to take a deeper dive into these two things. And, you know, PRP for another day, if you like. Okay, so let me just move on. And let me just. Okay, so my full-time job really is as a sports physician. I'm a full-time clinician. I've got a lot of voluntary work. I chair the sports medicine section in the Academy of Medicine and have several other appointments, and these are all voluntary roles. I work with a group of 8 orthopedic surgeons and 1 neurosurgeon. And I'm actually the only non-surgeon in the group. I'm a sports physician. And if you look at the names on the right side of the screen, you might actually, some of you in Hong Kong may know some of them, some of my colleagues. This is the clinic where I work at in Camden Medical Center in Singapore. It's a very distinct building, which is built by a world-famous architect by the name of Richard Mayer. And ordinarily, I would be saying that I'm speaking from there, but today, being evening and I finished work, I'm now speaking from home, which is an undisclosed location. Now, first, in perspective, you know, the COVID-19 pandemic has actually put some pressure on the orthopedic community to up our non-operative management game because of the risks of surgery. So this is just reflective of that, this article which appeared in this journal. Now, I just want to put on screen the nice guidelines which address intra-articular injections, and here you can see them. Intra-articular corticosteroids should be considered as adjunct to core treatments for the relief of moderate to severe pain in patients with osteoarthritis. And it says, do not offer intra-articular hyaluron injections for the management of osteoarthritis, dated 2014. Now, if we just listen to these guidelines, that's the end of today's lecture, and that's the conundrum resolved, isn't it? But we know life is not that simple, and most of us are clinicians, and we know that this cannot simply be true for every single patient. And indeed, if you look at these very same guidelines and you just go into the preamble, a lot of people just jump across the preamble and go into the content. But if you go into the preamble, you see this statement which says guidance does not override the individual responsibility of healthcare professionals to make decisions appropriate to the circumstance of the individual patient in consultation with the patient and or guardian or carer. So basically the responsibility goes back to the healthcare provider, whether you decide such a guideline would apply to your patient. And here, then we go to this thing called clinical reasoning for clinicians. And I'm very much always dwell on this model when I talk to people, because I feel that as clinicians, we cannot simply follow a guideline like a recipe book unless you are totally unfamiliar with the subject and you have no other knowledge than to follow a guideline. But for those of us in the musculoskeletal field, I think it is we are actually, we should really take it ourselves to go beyond the guideline. And so what are the pillars of clinical reasoning? Very briefly, mechanistic reasoning, reasoning from first scientific principles. We all train to some degree of that in our med school and in our postgraduate studies. Apply the clinical experience that you have using the particular technique which you intend to use or which you are considering. Look at the available published literature, whether it's RCT, whether it's uncontrolled, whether it's anecdotal, all have value. It may be an RCT that is available, but the RCT may have absolutely no relevance to your patient. And the last but not least is to apply the patient's values and your own professional values into the judgment. What this means is that if a patient tells you that, well, surgery is my last option, I'm really, really against surgery. Or if in my context, in a sports medicine setting, sometimes we have a patient who tells me, well, I've been training for 2 years and my competition is 2 months away. And I know if I wait for 6 months, I'll be okay, but can you get me better in 2 months? So sometimes this has to be put into the context of the clinical situation. So if you want to read further about clinical reasoning, because the reason I always put up this slide is because I feel there's just too much emphasis on just published literature and not enough emphasis on clinical judgment and all the other parameters, all the other pillars, all the other legs of this chair, which we really need to have balanced care for our patients. So really, when it comes to corticosteroids versus hyaluronic acid, we need to understand the effects and the mechanisms of action within the osteoarthritic joint for both of these. And this really is what mechanistic reasoning is about. We need to understand whether there are safety issues and whether they pertain to a particular patient's situation. We need to integrate our experience with whatever is published, and which means we need to sort of keep in touch with what's published as well. And then we need to know whether all this applies in just our particular patient sitting in front of us. Now, with that, let me just launch straight into corticosteroids for osteoarthritis, and I'm just gonna talk a little bit about the history. Hydrocortisone acetate was first introduced in 1951, sometime before I was born, and in this publication they reported subjective pain relief with few side effects in about 8,000 over injections. Side effects were just 2.3%. And these were just typically local type side effects. But about 8 years later, Chandler and Wright talked about interference with normal protective processes. Their contention from a study of 18 patients, 10 out of the 18, they noticed had accelerated joint destruction following prolonged intra-articular corticosteroid therapy. And that was being given 1 injection per month. And what happened was they thought that it was because they felt better and therefore they were able to do more things and load their joints more, and that encouraged undue weight bearing and mobility and accelerated the joint destruction. And I don't know about you, but when I was a medical student, I remember actually being told that too many corticosteroid shots would result in Charcot's joints, Charcot's arthropathy. And this was also reported by Chandler and Wright and Jones in 1959. Now, and I remember seeing this actually in a medical textbook many, many years ago as well. The radiograph of a hip in 1951, which was osteoarthritic, and after receiving injection after injection of hydrocortisone, it was completely destroyed, and it didn't look very much like a hip anymore by the time you look at the picture on the right. So let's fast forward now to this era, and this was a nice review in 2019. Now, the current evidence suggests that synovial inflammation is a key player in knee osteoarthritis, and particularly where it concerns pain in the knee. It is not the only player, but it is a key player. And corticosteroids primarily target the synovial membrane. And the most likely the mechanism of action is modulation of synovial inflammation, and it binds to activates some of the glucocorticoid receptors and produces various anti-inflammatory responses. So Synovitis is fairly easy to pick up if in a clinical setting, if you have an ultrasound machine, and you can usually put it onto the patient and you can actually see evidence of synovitis. And if you think, I guess, that synovitis is a big problem in a particular patient in front of you, then why not consider cortisone, right? So the therapeutic efficacy of intra-articular corticosteroids is known to be relatively short-lived, and it's perhaps due to a rapid efflux of the corticosteroid from the joint into the systemic circulation. But this is a double-edged sword. It leads to corticosteroid-related systemic effects. Just a quick table here, a summary of some of the more popular corticosteroids, and I highlighted triamcinolone because that's the one which I think is probably the most popular nowadays, and certainly that's the one we have in our clinic. And if you look at that, at the duration of intra-articular action, hydrocortisone being the lowest and triamcinolone reaching about 3 weeks, right? So it is variable depending on what sort of corticosteroid preparation you would use. Now, the big concern with corticosteroid, so it acts primarily targeting the synovial, but the big concern is what happens to corticosteroids on the cartilage. And this has been the subject of a very nice review by Wernicke and co-authors, and it's published about 5 years ago. And I'm going to just share some of the key findings from this review. Substance by substance, it does give you some analysis. So for hydrocortisone, there's dose-dependent effect on the cartilage. Low doses, the structure is maintained. Nothing bad happens, but at higher doses, there's gross cartilage damage and loss of cartilage macromolecules. Same for methylprednisolone, but the effect seems to be pretty pronounced. The large doses would give you quite severe effects and affect chondrocyte viability, gross cartilage morphology changes. And if it's applied long-term in vivo, there's overwhelmingly deleterious effects on gross markers of cartilage health. So this paper actually summarizes a lot of different studies on this subject, basic science to clinical. Same for dexamethasone, dose and time dependence and on the toxic effect on cartilage. And the low doses, once again, maintenance of cell viability, high doses and longer culture times up over 3 days, detrimental effects. Same goes for betamethasone. So you see this pattern being repeated again and again. Low doses, no significant effect, high doses, chondrotoxicity. And for betamethasone, if you have benzalkonium chloride, there's quite a severe time dependency. It's chondrotoxic at 24 hours. And without benzalkonium, it's chondrotoxic at 7 days. So benzalkonium is sometimes added in as part of the preparation. Prednisolone, time dependent again, below 6 hours, no change. After 24 hours, chondrotoxicity. You see this pattern again and again. Now let's go to triamcinolone. The results seem to be a little bit conflicting. There are two in vitro human studies which shows that it was chondrotoxic at all examined doses, but some in vivo animal and human clinical trials support possible chondral protection. Again, a dose dependency. And one human clinical trial, which was by Ronald, and this was in 2003, I believe, that study, which showed that three monthly, that means 4 injections a year, of triamcinolone acetonide given over 2 years seemed to prevent joint space narrowing on X-ray. All right. So just a quick summary of what these results showed. Generally speaking, in the last column, you'd see more negative than positive effects on the cartilage. And I think the net analysis of all of this is that cortisones do have a time and a dose-dependent effect on articular cartilage. There may be possible benefits at low doses and durations, but I think these sort of margin is quite narrow, and detrimental effects at high doses and longer duration exposures. So let's now look at some of the clinical studies of corticosteroids for osteoarthritis. And all of you are familiar with this evidence pyramid. where the top of the pyramid represents higher quality evidence. Filtered information means you're analyzing, doing a meta-analysis or systematic review, and unfiltered is at the bottom. And what I'm going to do is just take the top level studies at the upper levels, right? Before we go into that, there are just two things about clinical studies on osteoarthritis which you need to be mindful of, and Dr. Metsavaht sort of alluded to it a little. Number one is that most clinical studies use clinical knee scores. Most, but not all, but most studies, the majority of them, use some measure of pain and function, some subjective measure of pain and function to determine the outcomes. The second is that cartilage has no nerve supply. And this is very important because when we talk about osteoarthritis and cartilage being very central to the whole picture, and it has no nerve supply, we can't really say too much about the state of the cartilage on the basis of a subjective score. So the Cochrane review, so all of us look at Cochrane, which is supposedly, it's right at the top of the pyramid. It's a good meta-analysis. And the outcome of the review is that intra-articular cortisone injections are more beneficial than placebo or no treatment. And we all know this pain reduction and functional improvement can occur. Improvements are generally short-term, less than 6 months, and they tend to decrease over time. It may be better at 3 months, still okay at 6 months, but after that may not have substantial improvement. There seem to be no substantial differences with respect to side effects or major adverse events. This is the Cochrane review. But so that was 2015, and this JAMA article popped up in 2017 what they did was they used a protocol which was supposedly safe and measured cartilage volume by MRI over 2 years. The protocol was 12 weekly triamcinolone injections. The control was there was significantly greater cartilage volume loss with triamcinolone after 2 years, but there was no significant difference in knee pain. And this actually seemed to suggest that you could keep the knee pain at bay and still lose cartilage over time. This is a study which appeared in just last year in 2020, and it was about just a single intra-articular corticosteroid knee injection, and was found to reduce the meniscus thickness with no treatment effect on cartilage volume. It was case control. It was what they call nested case control using a sort of a registry, and there was no significant effect on rate of cartilage loss, but there seemed to be a transient increase in the rate of loss of meniscus thickness in the year they received the injection. We don't know the clinical significance of that, but it was an interesting finding nonetheless with a single injection. Now, there have been some concern about whether the steroids would cause harm in the joints. If you sort of look at the whole history back from the 50s with the reports of Charcot's joints, so I was actually quite surprised over the years that steroids are still so much in the picture. It's probably because they are that effective, but I think we have to be cautious with that they could, and it's expressed in this article, they could accelerate the osteoarthritis. They could be associated with subchondral fractures. They could be associated with osteonecrosis and a more rapid joint destruction on the whole. So I think that this in that sums up the main concerns with steroid, at least from the orthopedic angle. But if we look at all the risks of intra-articular corticosteroids, they are quite numerous. You might get post-injection flares, skin atrophy, and of course the accelerated degradation. And of course, there are some reports of possible increase in infection and possible increase in post-op infection following a corticosteroid injection pre-op. Systemically also, we have to be a bit concerned because facial flushing, Cushing syndrome, and that's when it affects the hypothalamus pituitary axis, loss of bone density, hypoglycemia. Now, the hypoglycemia is a real problem. It's been found in this review that all the studies in the review actually showed a rise in blood glucose in diabetics following intra-articular corticosteroid. Some took several days, and therefore the recommendation is to, if you have to do a corticosteroid injection in a diabetic, that you should have the blood sugar monitored more carefully for a week following the IA corticosteroid. And a lot of patients who have glucose monitors can do this on their own. So there have been instances where diabetic crisis has occurred and following corticosteroid injections. So we have to be cautious in diabetics. And bear in mind, a lot of the osteoarthritic age people are diabetic. The next thing was this interesting paper which came out just this year in the British Journal of General Practice. And it talked about orthopedic corticosteroid injections and the risk of acute coronary syndrome. Now, this is actually based on 60,000 ortho visits in Israel, where there is sort of, I think it's a state healthcare system. So all the treatments are taken care of and they are able to collect very good data. And basically what they found was that the risk of coronary event was 227 in a corticosteroid injection versus 31 events per 100,000 visits within the first week of receiving the injection. So the conclusion here was that it could perhaps increase the risk of a cardiac event after the injection. Right? Here's another one, which is a bit more topical. Does corticosteroid increase the risk of COVID-19? And we know that a corticosteroid may increase the risk for influenza, but at the point of this, when it was written in August, published in August last year, it's unknown for COVID-19. But the speculation is that the serum cortisol is significantly suppressed for 1 to 4 weeks, and this could have an impact on immunity. So I think we need to exercise a little bit of caution with corticosteroids, you know, a little more than usual in the pandemic times. And the last but not least, in my world of sports medicine, we have to be concerned with this. And I think if there are some Malaysians in the call here, I think you'll know who Lee Chong Wei is. I'm sure all of you who follow badminton know who's Lee Chong Wei, and you would have heard about the doping scandal he faced back in 2014 when he was found in competition having dexamethasone. The picture on the left is a British cyclist, and he was having triamcinolone. He was found with triamcinolone. The thing about this is that these are banned in the world of sports. And even if they are given intra-articular, meant to be a local injection, they would go into the systemic circulation and they might get picked up. And your athlete, after all this training, might get sanctioned. And it just leads to a lot of problems with doping, all right? So just be mindful of that if you're giving it to an athlete. Excuse me. The last but not least, if you have a person with a painful knee, cortisone is not the only answer. This study shows that physical therapy was pretty much able to outdo cortisone, in fact, in reducing pain. So it's just a reminder to us that don't only think of doing injections, you know, physical therapy is pretty much a powerful tool as well. Now let's talk a little bit of hyaluronic acid for osteoarthritis. First thing I want to say is that hyaluronic acid has no doping issues, right? It's never been on the prohibited list, and it's not on the current prohibited list as well. So that's one thing off your mind if you have a competitive athlete. Now, if you look at the guidelines concerning hyaluronic acid for osteoarthritis, they are pretty mixed. And here's just a little sprinkling of them. This article actually attempted to just analyze the clinical practice guidelines with regards to treating osteoarthritis with HA. And so they used 10 CPGs. They found that the methodologies for determining the guidelines seemed to be rather inconsistent. And it was a spread where it was 30% against, 40% uncertain or silent, and 30% recommended in certain scenarios. So it's a pretty mixed picture. A bit about the history of hyaluronic acid. It was actually discovered for the first time in 1934 in the eye in the bovine eye, and it's a glycoaminoglycan, and they named it hyaluronic acid. And subsequently, it was found in other organs and tissues and so on. And it can also be produced via microbial fermentation. And the concept of viscosupplementation, however, was started only in the 90s. It was first proposed by Ballas and Dellinger, and it was in this article in the Journal of Rheumatology. The hypothesis was that when you inject it into the joint, it could restore some of the rheological properties of synovial fluid. It could promote endogenous synthesis of higher molecular weight and perhaps more functional osteoarthritis, and therefore improve pain and function. The purported mechanism, therefore, is that there's a mechanical component of the mechanism on the joint surface, and there is a metabolic type effect as well, and induction of DHA production, reduction of inflammation, and so on. There is a protective effect shown in this study, which was in 2012 actually, and what this was using was urinary CTX2, which is a excretory product of collagen 2. And so the level of urine CTX2 excreted in the urine correlates in general with severity of osteoarthritis. And what the study showed was that 90 days after receiving the hyaluronic acid, the urinary CTX2 level significantly decreased compared to a baseline. So they concluded it suggested a slowdown of degradation of the cartilage. This paper, this is kind of a summary of the effects of hyaluronic acid. So both physiological maintenance of viscosity, rheological lubrication, and then the pharmacological side of things. But if you want to read one paper on the anti-inflammatory effects, which seem to be fairly numerous, I suggest reading this one by Roy Altman, and it's a fairly recent paper in Cartilage. And basically, it is in the review, they concluded that it was mediated through receptor binding with several different things, CD44, toll-like receptors, etc. So this article is a pretty good summary if you're into the molecular side of things. This is his model, and the interesting thing, this is found in the same publication, and you find that the higher molecular weight hyaluronic acid promotes anti-inflammatory responses, but the shorter oligosaccharides may produce inflammatory reactions, may be more pro-inflammatory. So higher molecular weight seems to be more beneficial. So if we look at clinical studies again, so this is a systemic review of meta-analysis. So you take a bunch of meta-analysis and they do a systemic review of them, supposedly one level higher than a meta-analysis even. And the conclusion out of this, with 14 meta-analysis and 20 over 1,000 patients, is that HA, intra-articular hyaluronic acid, is a viable option for knee osteoarthritis. It results in improvement of knee function and pain up to 26 weeks, about half a year, a good safety profile. Now, this is another review which appeared in JBJS 2 years ago, and a systemic review, again, of 10 meta-analysis. So there's so many meta-analysis now that you have to do systemic reviews of them. And the conclusion of this was that high molecular weight HA has the strongest evidence for what's clinically important and clinically important and significant treatment effects. In this same review, platelet-rich plasma also came out positive with the highest effect, but it was much more inconsistent compared to hyaluronic acid. So when it comes to hyaluronic acid, there's a whole bunch of them out there, and there's a whole lot of choices. And not all of them are the same. There are many different products on the market. The origin of the product could be one of the differentiating points, whether it's avian or by biofermentation. Hylan is a derivative of hyaluronic acid. There are a variety of molecular weights from low to high. Generally above 1,005 to 2,000, perhaps we would consider as high. And even in the normal joint, you would get a variety. right? But generally, the healthier the synovial fluid is, it more veers towards the high end. There's non-cross-link, cross-link combination. There are different concentrations, and whether they incorporate the sugar sorbitol or mannitol. Why is this important? Because sorbitol sugars protect the hyaluronic change from degradation, and this is a study which was in 2013, I believe, and they were showing that Sinolis, which has got sorbitol incorporated, is able to withstand stress from free radicals. So the resistance to free radical degradation is much higher when you have sugar incorporated. So when you choose a hyaluronic acid, it's good that if you have some data to back it up. There's so many out there. There are a lot of some pretty generic ones. And I have permission of Apterson to just give a few slides on this. This is a study which looked at a Sinolis VA, which has got hyaluronic acid and sorbitol, versus Synvis 1, which many consider a gold standard because there are lots of efficacy studies using Hyland GF20, that's Synvis 1. And it was a study on articular pain and mobility associated with knee osteoarthritis. So basically, it was it was a comparative study. Comparison point was at 6 months. And basically, the idea was to compare Sinolis against Synvis 1, which was a gold standard. And the result pretty much showed that they were quite similar, even bearing in mind that Synvis 1 has a higher volume than Sinolis VA. And we know that there's a volume effect, because when you inject a placebo with, it's just volume of saline, you already start getting an effect. So it's a 4 ml preparation versus 6 ml. They were almost equal. The conclusion in this was that the WOMAC pain scores, the conclusion was that Sinolis is quite similar to Synvis 1, not inferior to Synvis 1 in this study. So I think efficacy is quite reasonably shown in this study then, if it matches well against the gold standard. Now, one of the concerns with hyaluronic acid is about safety. If we are concerned with the injectate which we use, whether it's steroid, or hyaluronic acid, we also have to look at the safety considerations in hyaluronic acid. So again, meta-analysis of RCTs, and this one published by Miller in 2019 shows that it's safe for use. There is a bit of an increased risk of non-serious transient local reactions, no additional safety risks, right? And this is another study, again in the same year, and then systemic review and meta-analysis, and no major safety issues, but the quality of data is more low to moderate certainty. And they said that if you were to give it together with OA medications, there seems to be, on the data, slightly higher risk of some serious adverse effects, so possibly related more to the medications. What about repeated hyaluronic acid? Because patients sometimes get concerned, oh, I cannot take steroids, too many steroids, but can I take hyaluronic acid, again and again? And I think the conclusion of this review was that it was safe. It doesn't increase the safety risk if you give repeated injections. So this is a very important consideration for us, because osteoarthritis is a very long drawn disease, and you might have to keep the patient on some maintenance mode with your injectate over time. Now, what about hyaluronic acid directly against corticosteroid? And this is a study which compared the two in 3 different groups. Group A and B were using different molecular weight hyaluronic acid, and group 3 was triamcinolone acetate. And the result was that after 6 months, so the result at 6 months showed that the hyaluronic acid groups did better than the glucocorticoid group. The WOMAC scores, all groups were significantly reduced, and all groups significantly reduced analgesic and NSAID usage. So positive for all groups, but at 6 months, hyaluronic acid was the better performer in this study. Now, this is a meta-analysis, again, looking at hyaluronic acid versus corticosteroid. And the conclusion of this, as we would suspect, is that corticosteroid is more effective on pain relief in short term, up to 1 month. And hyaluronic is probably more effective in the long term, up to 6 months. Hyaluronic acid was associated with more local adverse events, but these are the non-serious adverse events. What about the union of the two? What if we sort of married hyaluronic acid with corticosteroid? Would that be a good idea? Would the hyaluronic acid mitigate against the bad effects of corticosteroid? And this study, this study just looked at the union of the two, compared them against hyaluronic acid alone, and found that no difference in adverse events, but there was greater reduction in pain of the combination compared to hyaluronic acid alone. Now, in trying to find data on what the protective effect was, and there's really not much out there. This is a study on porcine cartilage explants. And what they did was they exposed the porcine cartilage to dexamethasone and prednisolone with and at various doses with and without hyaluronic acid. And then the chondrotoxic effects were examined. And the result was that the addition of hyaluronic acid to dexamethasone or prednisolone did not seem to have a significant protective effect or no enhancement. So I think it's still a little out there, whether if you use a combination, are you actually protecting the cartilage? And my own take of it is that I would sort of base it on the corticosteroid. I would look at them independently, and the corticosteroid, the frequency of administration, you would still want to use it sparingly, and you don't want too much exposure of the cartilage to corticosteroid. There's just 2 more things I have to say. One is that we have to be very cautious with local anesthesia. We've been talking about injectates in terms of corticosteroid and hyaluronic acid, but the local anesthesia, which a lot of people put together the hyaluronic acid, and a lot of people put together corticosteroids, and some put them together with hyaluronic acid as well. If you put that intra-articular, there is a chondrotoxic effect. It is type and dose dependent. So there's some good reviews out there. So I just want you to be cautious about all this, right? So try not to put intra-articularly any local anesthesia as far as you can help it, if your goal is to try and preserve the cartilage. The last thing I have to say is that the knee injection technique is really important, right? To be successful with any of these methods. So you need to be sure that your placement of the knee intra-articular is indeed intra-articular. You would know when you inject, because extra-articular injections are extremely painful. They tend to be more painful, tend to have this local reaction. And I suspect some of those local reactions which you see reported in the literature are actually extra-articular injections. So depending on approach, you get 71 to 93%. It's more difficult when the knee is osteoarthritic. Your spaces become smaller, your access points become smaller, right? The lateral patella and lateral suprapatellar injections are the favorites of most people, including myself. Ultrasound guidance improves the accuracy. Patients need to be comfortable and relaxed. And when the needle goes into the joint, even without local anesthesia, and you are giving the injection, it is usually painless because you're just injecting into a cavity. So this is me doing a lateral patella injection. We just go for that space between the IT band and vastus lateral. This give the patella a little push to the lateral side, and it opens up the gap, and we hit for this. We direct the syringe in the center of the patella. Sorry, this is PRP injection. It's not the hyaluronic acid. It's yellowish. So this ultrasound guidance, and Dr. Metsavaht said, it looks beautiful when you inject on the ultrasound. I'll show you how beautiful it looks. Some of you do it, you see. So you can see the hyaluronic acid going in very nicely into the. So this is given suprapatella under ultrasound guidance, and you can see it going very nicely into the cavity and painlessly as well. Oops, sorry. Let's move to the next slide. So in conclusion, corticosteroids probably shorter-term effect on osteoarthritis. Hyaluronic acid longer term. When you think of cortisone, corticosteroid injection. We are targeting the synovium, but bearing in mind there's potential collateral damage to the cartilage, which is dose and time dependent. There could be local and systemic side effects. And I would only use it if I was convinced there's clear evidence of synovitis as the main cause of pain. Because as you know, osteoarthritis, the pain is not all about synovitis. There could be bone marrow edema. There could be a neuropathic sort pain. Sometimes the pain is just muscle spasm. Not all osteoarthritic pain is synovitic from the synovium. Hyaluronic acid targets the synovium and cartilage and may give limited mechanical protection, and you only get local side effects. And high molecular weight is probably more effective. The combination gives greater pain relief, but we don't know whether the HA truly mitigates against the potential chondral damage from corticosteroids. And with that, I'll end my, I'm sorry, not yet. Just one last thing. So as a clinician, again, when you are meeting your OA patient, you have the choices. If he's been receiving corticosteroids for a while, you may not want to give anymore because you have to use it sparingly, and you just don't want to have too much collateral damage on the cartilage. What's the urgency of pain relief? Does he really have synovitis? What's the state of his cartilage? If he's got not that much cartilage left, do you want to destroy it all? Does he have a medical contraindication or a medical risk? Does he have a doping risk if an athlete? And to me, it's quite simple. If you are in doubt whether you really want to use corticosteroid, just use the HA, because it is all about safety first, in medicine. So with that, thank you very much for your attention.
Sorry, maybe my sound was blocked just now. May I repeat? I can see many questions from the chat box and also from the Q&A box. Let me ask the speakers. Let me ask the speakers to answer them one by one. First, Dr. Kinematic asking about the speculations on viscosupplementation versus steroid versus PRP, and the indications and usage of each modality. What is your opinion for the two speakers about this? Maybe Leonardo first.
First of all, thank you, Jaden. First of all, I would like to congratulate Dr. Go for his presentation. It was really didactic and easy to understand with meaningful informations. Congratulations, and thank you very much for sharing it with us. Okay. Secondarily, well, answering the question, I have no experience with PRP because in Brazil it has been forbidden. Only for clinical trials it's allowed. It was in market for about 2 or 3 years, and then the government took it out for some reason. I used only in a few surgeries, muscle surgeries, etc.
So how about Patrick? Do you have any experience on PRP?
Yes, I do. So I've been using PRP for the last 13 or 14 years. Now, I think PRP is a good tool to have in our box, right? So, steroid is a tool, hyaluronic is a tool, PRP is a tool. And I think the selling point about PRP, so the strength of PRP really is that it's autologous, and, we don't worry about allergic responses and stuff like that. The basic science behind PRP seems to be fairly well grounded. The clinical studies on the whole seem to show an equal or slightly better effect than hyaluronic acid. The weakness of the PRP studies is the variety of PRP being used. And if you look at over the years, people have tried using leukocyte-rich, leukocyte-poor, and so many different varieties. Some just what they would call plasma-rich in growth factors without the platelets even. Now, I think the challenge for the PRP and the biologic community is really to not just throw everything under one label, but to try and define better when you do a study what exactly you're putting in. And I think that's the emphasis for anybody who wants to use PRP. To me, it is a question of like, if I'm saying this patient gets better with physiotherapy, that patient didn't get better with physiotherapy, and a physiotherapist will just ask me what physiotherapy was done. What does the word physiotherapy mean? It's not a singularity. It means so many different things. So if we can define, and it really is a whole different, whole lecture in itself, what exactly are we injecting? And I would say that our understanding right now is a lot better than it was 10 years ago of what works in PRP, but it's not complete by any means. But we do have better understanding now than we did have 10 years ago. Briefly, I'll just say that what works is better is leukocyte-poor PRP into the knee. You can see several publications on this. And what works, and PRP works pretty well in combination with hyaluronic acid. There is some pretty good positive studies showing that the combination of hyaluronic acid and PRP seems to outdo either of them individually over the course of a year, with the hyaluronic acid showing some advantage, especially in the earlier period. Now, the question also asks about what if we put in steroid into that mix, so we just throw everything into the soup. So there was some in vitro studies looking at PRP and steroid in combination, and whether the PRP was able to mitigate the bad effects of steroid. And there was some possible reduction in some of the pro-inflammatory activity when the pro-degenerative activity when you added PRP and steroid together. But I'll say it's really, really early, and we can't be sure. There is a possibility as well that the steroid mitigates some of the cytokine actions, the growth factor actions of PRP. So it is a very complex question. In my own practice, I don't combine them. All right, it's very clear for me, if there is clear synovitis and I'm sure that the synovitis is the cause of pain, I might put a low dose of steroid in there. But that would be the immediate measure, and then I would start thinking of the longer term measures where I would think more of PRP and hyaluronic acid. Now I was about to answer the first question there as well, about strengthening from Dr. Wong Chin Kong, and strengthening is not suitable under pain. If there is neurologically caused pain, is it suitable for OA patients to train the muscles? I think the answer to this, actually, Dr. Metsavaht alluded to it. When a joint is painful, you're going to have a lot of inhibition of the muscles over the joint. And it's not easy to try to strengthen. You have to address the cause of pain. You need to lessen the pain somehow in order to create the window for the person to be able to rehabilitate. So if there's, now, if whatever the source of pain, if you're sure it's neurologically caused, then you may have to try to address that before you can really rehab it by whatever means you have. And I think it's a bit out of scope of this talk to talk about how, to address neuropathic pain. But my take on it is that pain is an inhibition. It is a stumbling block for rehabilitation. It is a little bit of a vicious cycle. And if you've got to get rid of the pain in order to start strengthening, and as you start strengthening, you can actually address the pain better. You can actually, you can try and break out of that vicious cycle. Thank you.
I think both of these presentations, they were very complementary one to another. It was a marvelous combination of presentations, because my skills are in biomechanics. So I don't deal too much with inflammation or the type of hyaluronic acid. That's not those are not my skills. My skills are biomechanics. So what the study we performed over here could be performed with any medication. I could use a anti-inflammatory, oral anti-inflammatory, to do the same biomechanical analysis. The point is that we try to show people is that not only we don't only have to expect chemical or inflammatory changes. As physicians, as we are, our patients, they want to regain function. They want to get rid of pain and regain their lives. They want to walk. They want to go shopping. They want to go to market. You know, they want to live their lives. And that's our measures. Whenever we regain function, we simply use these these computerized tools to measure function for real, instead of just those questionnaires of function or pain, you know. So that's what we could measure with Synolise. And there are about 6 papers coming out for that. And all the results I showed in this presentation, they are preliminary results because the full results are being analyzed for scientific periodicals all over the world. So we cannot release all of them. So, but the final results are much more robust than what I showed over here. The functioning, the gait, and crouching of the patients improved a lot after the use of Synolise.
I think the first 2 questions in the Q&A box has been well answered, including the strengthening and also the PRP, HA, and also steroid combinations. And then we then go to the third questions about the combining the hyaluronic acid in acute knee pain and also chronic knee pain. What about the chronic knee pain? Is it also useful for the combinations?
As far as I'm concerned, you know, from my own personal view, I try to avoid steroids as much as I can in a weight-bearing joint like the knee, unless there is a real need to do it. And so in a chronic knee pain situation, the question I would ask myself is synovitis a key component of that chronic knee pain? And if I can find clear evidence that it is, then I might consider putting steroid in there. Usually I sort of take the stand that putting steroid in the knee has to be earned. You know, it's not a default position at all. The patient has to earn the steroid, you know, by showing me that they have synovitis in there. Because a lot of times when you do MRIs to the knee, sometimes you see actually it is, you know, it is maybe an area of bone marrow edema. So here it's actually quite good to pause and just consider what causes pain in osteoarthritis. And it's important to remember that only things with nerve supplies can cause pain. Cartilage does not cause pain, all right? That's an important thing. And that's the main critique I have of a lot of studies which just use subjective pain, because, you know, cartilage loss is very central to the whole osteoarthritic process, but cartilage does not have have the ability to send pain signals to our brain. It's the synovial membrane, it is the capsule, it is the muscles, it is the menisci, it is the fat pad, it's the bone. So which of these is causing the pain? And as much as we can, we should try to establish. Sometimes we can actually localize pain. And I forgot, it's the nerves as well. So the people in pain management will tell me, yes, don't forget neuropathic pain. Yes, I agree. Now, it's not one thing. It could be a combination of all 4 or 5 things. We don't know which is the predominant one. And sometimes, you know, we look at knee pain and we examine the patient and we can find, very often I find actually the pain is extra-articular. It's actually coming from the pes anserine or the coronary ligaments holding the medial meniscus. You do the ultrasound scan, you see the medial meniscus is extruded out more than 50%, and you see the coronary ligaments around it are torn. And you touch that with your finger under ultrasound guidance, and you know that that's the source of pain. How do you address that? Do you put a steroid there? That's not synovitis, you know? So, yes.
Yes, agree very much.
I'd like to add something that it was not in the presentation. We were surprised because we had all this protocol perfectly done for the study, and we forgot to think of one variable. When the first patient came in, he had a huge effusion. And then the doctor who was doing the injection, he asked me, should I drain or not? And as the leader, I had to take the decision. So, you know, it took me about 5 minutes to think about it, because all the guidelines, they say to drain. It's a routine to drain, and then after you put the viscous supplementation. But I thought, well, if I drain, I'm going to be biased in this study, because only the drainage can provide some range of motion and minimize pain for that. So we decided not to drain, and we did not drain any of the knees. So we had knees that had effusion and knees without effusion, and most of them got better anyway. And you see, in our clinical practice, we are anxious to provide relief to our patients. So we start thinking, should I put some cortisone? Should I give some anti-inflammatory as well as Synolid and whatever? So we are anxious to help the person. So we start trying to combine things. And whenever we're in a scientific problem like this, I could not do that. And then I realized that, as Dr. Goes said now, sometimes pain is from other place, and we can suppose the pain is from somewhere or some other place, but we did not drain any effusion. We just put the Synolid, and the patients had some benefit anyway. So that may be opening a new door for researching hyaluronic acid, you know. So I have not used in my practice the combination of cortisone and the hyaluronic acid. I do it for many years. Actually, I do since 1998 or 2000. And I have never used cortisone. And now I have a scientific reason not to do that, because we increase their motion, we increase their function without any cortisone or even the drainage of the effusion.
I think in the checkbox, Dr. Malik also helped Dr. Go to discuss more on the slide shown with the various steroids and their clinical actions and time duration syndrome. Maybe Dr. Go can speak a bit more on this.
I think, well, I covered it as much as I can in the lecture, you know, because I would best refer you to the paper. I think that review showed very nicely all the various, all the various studies which were available, which showed, for every different steroid and what time it stayed, and so it's shown on the table in the slides. And if you like, I can send you the paper. I can send it to the organizers, and they can. It's an open access paper. I think it's a free article, so I just can give you the reference. You can read it, right? So it's a nice summary. And most of us just keep 1 or 2 steroids in our clinic. We don't have the whole lot. So we just look at the one which you are using, and I think you get to know more about it. Yeah.
One of the questions about antibodies to the hyaluronic acid, about the safety issues. Do you have any comments on this one?
I don't actually. I'm not too sure what the question refers to. What antibodies against the hyaluronic acid are there? Because there's nothing really. Do you mean something else? I'm not too sure what that means.
Right. How about Leonardo?
The same answer. I don't see any relationship.
Yeah.
And there is a question here about, actually it's an affirmation about, from Dr. John Lee, and that we should never forget that pain in the knee can come from other joints. Yes, of course. The hip is a very frequent cause of pain in the knee. We as good doctors and surgeons, when we see a patient, we should consider all these. We should examine the patient to see the range of motion of knee, of the hips and ankles to see if there is any reason. Usually here, I use those biokinetic analysis. Most of my patients I send to biomechanical lab to do the analysis, not only for my diagnosis, but for optimizing rehabilitation. As Dr. Go said, oh, send to physical therapy. What is physical therapy? Or what is it? Little chalks and shock waves and ice and stretching. Stretching what? Does that need, it seems that there is a package for everybody. And of course, we have talented physical therapists that can see what the patient needs, but unfortunately, like surgery, talent is not reproducible. So if one physical therapist is talented to diagnose and to do some physical therapy approach, it doesn't mean that all of them have the same talent and have the same tools. So we use over here biokinetic analysis for most of the patients. So the biokinetic makes a list of where are the potentials and where are the flaws of the motion of the patient. So in rehabilitation, they can focus on the problems optimized and not doing that package of rehabilitation.
I also see one of the questions from Dr. Lee Young-Fai about the knee joint with synovial fluid. And would you aspirate first and then give steroid to wait for the inflammation to improve? I think Dr. Metsavaht has already answered this one about his practice because both the hyaluronic acid can improve that for both conditions, whether you aspirate it or not. How about Dr. Go? Any experience from you?
In general, I look at the degree of effusion, and sometimes when the knee is effused, but the patient is still able to reach almost a full range, I actually don't bother to remove, because what we find, and I learned this the hard way with two patients who scolded me, one of whom was a dentist. When I followed faithfully the protocol of draining out the knee and drying it out, taking out the synovial fluid, and then I injected the hyaluronic acid, and he was on his way to the airport after leaving my clinic. He was from Indonesia, I believe, and he called me up and scolded me because he said his knee was now very pain. And what we find, the other side of things is that when you follow up these patients, maybe a week later, you find quite often the effusion comes back to a certain degree. So what I would do is really try to ascertain how much the effusion was contributing to some level of dysfunction, because I think for a lot of patients, when they are at a certain stage of osteoarthritis, it is almost physiological that the joint fluid levels increase to kind of buffer things up in there. And all I would do is just add in the hyaluronic acid, the high molecular weight, and hope that it has got its effects on the inflammation and so on. So I think this is my approach to it. As far as possible, again, for me, it is always a big issue, the collateral damage which occurs with giving a cortisone jab. I'm very cognizant of that I do not want to accelerate the guy's timeline towards end-stage osteoarthritis. So, I'm a physician, I'm not a surgeon. I don't earn any money when the patient has to go for surgery, for a total knee. So my job is to try as far as possible to keep him from the surgeon, right? To keep him from needing a total knee replacement. And I look at myself as a person who tries to hold the line on degeneration. That's my job. I see him at a certain stage and I tell him, this is my goal. I'll try and hold the line for you here, or at least let you advance as slow as possible. All right. So for me, that's why hyaluronic acid and PRP serves a much better function than cortisone would. And I'll only use cortisone if I think the patient, if he was really in pain and he was showing evidence of synovitis and he really wanted it, then I'll tell him, okay, I give you this, but it may accelerate you a little bit, right?
Dr. Go, something that I use in my practice, I have never used cortisone with hyaluronic acid. I see no reason to do that, but I use mesotherapy which is an European method of
Yes.
introducing non-steroidal anti-inflammatories subcutaneously in the region. I think that is a very powerful tool, because you use 1/20th of the dose of the anti-inflammatory the person would use orally. So there is no side effects, there is no risk of cardiological effects or whatever.
Yes.
And I've been treating athletes for the past 26 years, and athletes have pain, and if they use anti-inflammatories, they would use every day. So mesotherapy has been a marvelous tool to treat these patients. I have about 18,000 patients treated with mesotherapy for one problem or another. And it's a very good tool. So that's the only thing I associate with Synolase in my patients. If the fusion is big enough to cause restriction of motion and pressure, hydrostatic pressure in the joint, I use mesotherapy for 1, 2, 3 weeks the most. And then when the fusion is a little softer, then I use the Synolase. That's the way I do it. But I agree with you, knee osteoarthritis, it needs some kind of liquid joint, or some extra liquid joint. So whenever we drain too much, actually the patient complains of pain, because it starts increases the joint pain.
Yeah, thanks. It's interesting you mentioned mesotherapy, because I use it as well. I actually learned it from a French physician, and I use it mainly for Achilles tendon, Achilles tendon inflammation and tennis elbows, and sometimes around the knee. I tend to use it in the extra-articular, for the pes-serine tendinopathy, which is associated the medial joint line pain. But I've never really tried to use it to reduce a fusion, so I might try that. Second, just a little tip for those who are, trying to withdraw an effusion. What I found is quite useful is that, as you start to withdraw the effusion, and then you make a decision, do I withdraw everything or do I just withdraw a little bit? Because, bearing in mind that we still need fluid in that knee. What I do is as I withdraw it, sometimes I just untwist the syringe, and I just pull back the thing, and I just sort of get a feel of how viscous it is inside the syringe. Because, if you're withdrawing fluid, which is actually very viscous, then you maybe shouldn't withdraw too much, because that, and you can tell straight away as you withdraw it, and you just pull back, put a bit of air in that syringe, and you just tilt it up and down, just at the bedside, and you can see straight away whether it's a very watery sort of fluid. If it's very watery, I tend to take out more of it, and then I put in the hyaluronic acid.
See,
very good tip.
Yeah.
Right. So there is a question from Dr. Mandy Zheng. Is the study between Synolase and Synfus, were there significant difference in adverse events?
Okay, so in that study, I think they did report adverse events in both groups. I think it was marginally higher in the Synolase group, and certainly the Aptison people have to check me on this, but I don't think it was a level of significance. It was not significant. It was not in the final conclusions anyway.
Mm-hmm. So I also see the questions about the sorbitol. I think this question has already been answered by Dr. Goh's presentations. So, and about the arthroscopic debridement together with hyaluronic acid injections, any experience from both of you?
Okay, so I don't do arthroscopy. I'll defer to
maybe
my surgical colleague.
Maybe Dr. Metsavaht?
I do a lot of arthroscopy, and it's not myself. Most studies have recommended not to do arthroscopy before. Okay, there is no evidence that arthroscopy increases better results for clinical treatments. You should stay on clinical treatments. When we have a knee with osteoarthritis, don't touch the meniscus, don't touch, unless you have something really obvious to treat over there, a large osteochondral defect with the rest of the knee is healthy, but with one osteochondral defect localized, and unless you have a very localized problem on the knee, don't go inside. Don't go inside an osteoarthritic knee. It's like going inside an old house. Don't, if you move something from one place, you may find a bigger problem behind it. So there is no scientific evidence to help with osteoarthritic knees with arthroscopy. I know we feel like helping the person. We are physicians, we try, we want to make all our efforts to help them, but sometimes not doing, we are helping them a lot.
Mm-hmm. So, and also another questions about oral hyaluronic acid. It is very interesting. Do you think there is a prescription of oral form of this one? I haven't heard of that before.
I've seen oral supplements. I mean, it's sold in the supplement world. I'm not fully convinced. I think a lot of supplement research is a little bit, it tends to fall below the stringent clinical trial type research. But I would not say that I've really read up on everything. It's just that I've not seen anything really stand out for me for oral hyaluronic acid. And I think intra-articular still is, it has got much better data to support it.
I don't
I've
believe.
seen some of my patients take it too, and I can't really, I'm not
I
really
don't
convinced.
believe in oral supplements for that.
Yeah.
It's my opinion. Okay,
Yeah.
my opinion. I've been studying this for the past 25 years, and I don't see if that would help. Anything would help also your ears, your nose, your lips, and your teeth, and everything. So it's a kind of thing. This kind of molecules, they need to go straight to the point, straight where they are needed. Otherwise, you would need a ton of it to help you all over. So we need to do localized treatments. I try to do that with everything. Anti-inflammatories, I use mesotherapy instead of doing even to the whole body. And hyaluronic acid must be addressed to the joint, to the area that is needed, and not to the whole body.
Right. Okay. Two last questions. I think one of them about the mixing the triamcinolone with ISCO supplement. I think we have already discussed about this one. So we have one last one, from Dr. Lee. Do you agree that HA is used for dry, rough, painful joint, and steroid is meant for wet, swollen, painful knee?
Okay, for me, I agree with half of that statement. The first half, a dry, rough, painful knee. Okay, why is the knee dry? Why is it not secreting its own hyaluronic acid? Is the synovial dysfunctional in some way that it dries up? And so I mean, that aside, yes, I've in my own experience, when I see patients with dry and painful knees, I find the hyaluronic acid quite useful, and repeated injections probably, because this patient probably has got some dysfunction in the ability to secrete synovial fluid. And we hope that hyaluronic acid can stimulate some secretion. Now, again, steroid, to me, it is a simple calculation of whether synovitis is a big factor. And to me, it is not so much because in a knee with effusion and painful, what is the cause of that? Is it simply the effusion? Is it simply muscle spasm? Is it neuropathic? So to me, it is the steroid is indicated if I clear that it is synovitis which is causing this. If synovial membrane is to blame, in my best judgment, then I would consider a steroid. And in many cases, I would try other things first. I might even give oral anti-inflammatories, or as I've just learned, I could possibly try mesotherapy, to try and bring down a inflamed synovium, But I think because of the collateral damage, the potential collateral damage, and because, like I said, my role in this is to hold the line and not let the thing advance, I'm reluctant to give steroid just on the basis of a wet, painful knee.
I agree with Dr. Go. No cortisone. And I used to think that, you know, when you have a dry knee, is good for viscous supplementation. But after I conducted this research that was perfectly conducted, we observed that patients improved in pain and function, even with knee effusion, just like Dr. Go said, because sometimes our body needs some effusion. If you're more viscous, so hyaluronic acid may be simply increasing the quality of our synovial fluid. So my answer would be yes, I would use in dry, rough, painful knee, and I would in the wet, swollen, and painful knee as well. I have no conflict of interest with the medication that we are talking here about. I am a biomechanical researcher. I research anything in biomechanics, you know. So I would, because I've seen and I did that scientifically in a RCT.
Okay, I think we have already answered all the questions from the Q&A boxes. And also, you two have delivered very great talks to all of us, and we learned a lot from you all. And I think this is now 9 o'clock, 5 minutes past 9 o'clock in Hong Kong. I think we have already done our job. Thank you very much. Maybe, is there any questions from our others? No more questions, I think. So thank you very much for your participations in this webinar. Let me close this session. Thank you.
Thank you, Jason. Dr. Leonardo, I hope to meet you in person one day. Thank you.
I also hope to learn mesotherapy from you too, because this is my first time to hear mesotherapy.
Yeah.
I've done that since 1992.
Okay.
A long way.
I
my master degree at the Federal University in Rio de Janeiro was on mesotherapy for shoulder tendonitis, rotator cuff tendonitis in 1999. I can send you a copy. I would be pleased to send you a copy of that. So I was very honored with this presentation, and I wish I could have Dr. Go's email contact. So I plan in the future to visit you in Singapore.
Okay, thank you.
Yes,
I'd like to visit Brazil as well. I learned mesotherapy from a guy, a doctor named Dr. Jacques Lacoste, a French doctor.
Me as well. He's a very good friend of mine.
Oh, he's a friend of yours. Okay.
He used to be the physician of the Paris Saint-Germain.
Yes, Paris Saint-Germain. Yeah, that's right. And he did this study on the Achilles tendon, and I found it really effective in the Achilles. And I've been using it mainly in the more superficial inflammation areas. And
after I learned with him, I brought over here and I opened this mesotherapy ambulatory at the Federal University of Rio, and we performed a lot of studies over there. So from 1995 to 2000, we ran a lot of research over there, and we published a lot of papers on mesotherapy over there. And it was in the Federal University that I met the gait analysis lab in 1996, and I got in love with it. It was very clumsy. It was very difficult to do gait analysis in 1996. So my chief would say, that's impossible. This is too workful. Said, Chief, don't worry. We just need to be smart on it. We need to be wise, because technology is coming our way. And now I lead the top laboratory in Brazil in gait and in motion analysis at all, with everything. And we have done fantastic studies on that.
Wow.
So it's very good to know that you too enjoy mesotherapy, and
Yes.
each one of us have different skills.
Yeah. Well, okay. Well, I'll take my leave now. So nice meeting you all. Thanks, Jason. And maybe you should hold a mesotherapy session in Hong Kong, right?
Yes. Maybe invite you to teach us the mesotherapy,
Yeah.
how to do it. Right.
Okay.
This is
It will be a pleasure.
Very.
Okay. I'll see you then.
Bye-bye. See you.
Bye.
See you.
Bye-bye. Thank you.
Bye.